Hi, everybody. It is my great pleasure to welcome you all to this post-Congress webinar dedicated to relapse refractory multiple myeloma. And we had in the last few weeks some key congresses, the COMy Congress in May in Paris, and we had ASCO, and more recently we had EHA. And obviously, myeloma has been, as usual, highly debated, and we have witnessed some very nice novel data being featured at these meetings. And to make a long story short, it looks like now that in the first line setting for newly diagnosed multiple myeloma, we're going to use quadruplet for the majority of the patient. In the transplant-eligible patient, VRD, daratumumab, bortezomib, lenalidomide, dexamethasone, as initially described in the Griffin trial, then Perseus more recently is being offered as an induction. It is also likely that patients are going to receive doublet maintenance like dara-len. In the older population, non-transplant eligible or not willing to proceed to transplant, we have also some fascinating results thanks to the IMROSE and so-called benefit trial with isatuximab and VRD. So in another word, actually, after the first line, all the patients are becoming immediately triple class exposed and maybe at some point triple class refractory. So that is a huge and very important, I would say, move in the way we need to envision the relapse refractory setting. And this is why I thought we needed to have a panel of experts to debate some of these issues when it comes to managing the relapse refractory multiple myeloma patient. And it is my pleasure to be joined today by a distinguished faculty, namely Dr. Paula Rodriguez Otero from Spain, Dr. Hermann Einsele from Germany, Dr. Jesús San Miguel from Spain, and last but not least, Dr. Joe Mikhael from the US. So thank you all for being with us today. And without any further ado, I'll throw the first question, and let's start with the CAR T-cell chapters, Guy. And we are all aware that we started a couple of years ago, or maybe more, 3 years ago, using commercial CAR T cells in the relapse refractory setting, advanced line. But now, thanks to KarMMa-3, thanks to CARTITUDE-4 trial, it looks like these CAR T cells are moving into earlier lines of therapies. What are your thoughts? Who are the patients who should be offered these treatments? And as usual, I would say ladies first. Paula.
Yeah, thank you, Mohamad. A great pleasure to be here. I think that the data that was presented, particularly at ASCO and EHA, alludes to this point, because some of us may feel that, for example, in the CARTITUDE-4, only 25% of the patients were indeed exposed to prior anti-CD38 monoclonal antibody. It's true that the data in the trial clearly speaks in favor of using cilta-cel in early relapse setting, and the PFS benefit and the overall, the CR and the MRD benefit for cilta-cel over a standard of care is clear. But some physicians may believe that, okay, if my patient is not yet triple class exposed, maybe I have the chance to use an anti-CD38-based therapy in second line and use cilta-cel eventually later. And in the ASCO and also at EHA, I believe there was this presentation focused on patient relapsing early and with functional high risk. And in fact, the benefit for these patients that were enrolled in the CARTITUDE-4 was even higher. It was even more pronounced, I would say, for cilta-cel over standard regimens. So if I have a patient today, young patient eligible for CAR-T, in second line, that, for example, progressed later under len maintenance, 5 years on maintenance, in that patient, I will probably go, if a standard is, to an anti-CD38 plus KD, for example, combination in second line. But if it's high risk, functional high risk, I will probably go for a cilta-cel in second line.
Thank you, Paula. Joe, what is the situation on the other side of the Atlantic?
Yeah, I seem to be the sole representative on this side of the Atlantic, so I'll try to represent as well. But it's just always a pleasure to be with you, Mohamad, and these three individuals who I consider both colleagues and friends. So it's wonderful to be with you. I think Paula highlighted some very key points, and what was very reassuring to me, really discussed at all the three meetings at COMy, at ASCO, and at EHA, was this notion of functional high risk. I mean, to be pragmatic here in the US, we can't give everybody at first relapse a CAR T just by sheer volume, by sheer access. And I do think that as we, like with every drug in myeloma, we go through an evolution to increase efficacy and reduce toxicity. And we're really working on the toxicity standpoint, understanding particularly the neurological toxicities and reducing them, because I think we've done well at reducing the infection risk. So as we bring the drug earlier, or the strategy earlier, we have less willingness to accept risk. So we want to make it safer as we bring it earlier in early line. And so when we look at that group of people that Paula mentioned, both in CARTITUDE-4 and in that subset in KarMMa-2 that Xavier Leleu presented at EHA, we see these people who are relapsing quickly, whether or not they've had transplant, 18 months, which we know is generally a marker, sadly, of long-term poor prognosis of patients. Because once they relapse quickly the first time, they're likely going to relapse very quickly thereafter. And I was quite comforted to see the data showing to us that, for example, even with ide-cel, with a greater than a 2-year PFS in that higher risk subgroup, what was impressive. Granted, the numbers weren't huge, but it's giving us that signal. So in answer to your direct question, here in the US, we're typically prioritizing that functional high-risk individual, whether they have high-risk cytogenetics or not, that when they relapse quickly after their first strategy, that we're considering going to CAR T-cell therapy. My last comment, which I know I don't want us to go on to another discussion, but it's interesting to me when we look at these studies that have evaluated those patients that have functional high risk, that have relapsed quickly, there's actually a significant proportion of them that do not have high-risk cytogenetics. So, it speaks to the complexity of myeloma, that you can't always predict upfront based on cytogenetics what's going to happen to a patient. And so this notion of including not just cytogenetic, but functional risk stratification, I think is important.
Oh, thank you, Joe. Hermann, would you agree with this position? Because for 3 decades, you've been an advocate of immune therapy and cellular therapy. So I would guess you would love to give CAR T-cells to everybody as soon as possible.
Well, first of all, thanks, Mohamad, for the kind of involvement in this great meeting today. Now, you're clearly right. I would rather prefer to use CAR T-cells as early as possible for several reasons. I think CAR T-cells depend on fit T-cells, and the less the T-cells are exposed to any agents, the fitter they will be. So that's the first reason. The second one, and we've learned this also from allogeneic stem cell transplantation, and I think several of us have been involved in the field of allogeneic stem cell transplantation. We know the later we give this kind of immunotherapy, the less likely the patient is going to benefit, and the more likely the patient is going to have side effects from this treatment. So to me, move immunotherapy to earlier lines of therapy makes completely sense to me. And I think CARTITUDE-4 and also KarMMa-3 have nicely shown that if you do it earlier, you increase the efficacy of the treatment and you reduce the side effects. And I think that was nicely shown that the hematotoxicity, the late neurotoxicity was less severe and less frequent when the CAR T-cells were given earlier. So I would actually argue for an earlier application of CAR T-cells, and I think that's the way to go. And then we know about the trials that are now ongoing CARTITUDE-6, CARTITUDE-5, we're already in first-line therapy. We are exposing patients to CAR T cells. And also, I think the COMy-9 is an interesting strategy when ide-cel is given as a kind of consolidation following autologous stem cell transplantation in patients with a suboptimal response. So clearly, I'm in favor of giving as early as possible.
Okay, thank you, Hermann. That's a very important point. So, Jesús, you know very well the CARTITUDE-4 results. You know the KarMMa-3 results. You have been involved in myeloma trials, and you have advanced the field a lot since 30 years or more. Now, based on what we know, what are the pros and cons in your opinion, and how can we guide our community on the wise choice?
Thank you very much, Mohamad. I think it's not easy to add anything new following the previous speakers, because they have really addressed the important points. Probably I could add something, and this is the reluctancy that some doctors may have based on the very good results obtained with CARTITUDE-1 in very late relapses, and they consider that are almost exactly the same results in terms of response rate and potentially PFS as the results that has been initially reported in CARTITUDE-4. Then one of the debates is early or to wait for a late line of therapy. For those people that has the reluctancy, I would try to refresh a date that is, I think, is really relevant, and is when we analyze in CARTITUDE-4 the patients that in fact receive the CAR-T, and we compare the MRD rate in this study, CARTITUDE-4 versus CARTITUDE-1, and we compare the PFS at 12 months, there is 10% already difference in favor of the MRD of used in early lines, 72, if I recall, versus 58%, more or less, and the PFS is again at 12 months superior by 10% in using in early lines. Therefore, I think all this, together with the fitness of the cell, reinforce the use of CAR-Ts in early lines.
Okay, thank you. I think we have a balanced opinion, and there are pros and cons, and I believe the choice will not be easy. However, I think Joe raised an important practical and logistical parameter, which is about feasibility and accessibility of providing CAR T cells to everybody. Even if we decide to give them to everybody, I don't believe, for several reasons, we will be able to do it. And this is why I am personally very excited about another form of immunotherapy, namely the bispecific antibodies. It's a fascinating, I would say, in vivo immune therapy. And instead of doing all the engineering manufacturing process, thanks to the bispecific antibodies platform, we are able actually to manipulate and maybe harness the immune system directly using an off-the-shelf vial, an easy, quick subcutaneous injection, and achieving a very rapid response within 1 month or so. And today we're lucky having teclistamab being first approved against BCMA. Then we had elranatamab also approved against BCMA. We do have talquetamab directed against GPRC5D approved and hopefully available soon in most places. We have seen just a publication very recently about linvoseltamab, I think, which is another anti-BCMA bispecific antibodies. And there is alnuctamab, which has been, I would say, developed at some point. And there are other, I would say, bispecific antibodies. So, Paula, what is your current feeling and your current use of bispecific antibodies?
Okay, so I completely agree with you. I think that these are very potent platforms of treatments that are providing a very high responses, deep responses, fast responses, and responses also are durable. So we can differentiate based on the target. So you mentioned teclistamab, elranatamab, linvoseltamab, and there is also ABBV383. So all the four are targeting BCMA. And I would say that at least 3 out of 4 are very well advanced. So 2 are already approved, and is eventually possible that linvoseltamab will also be soon approved as well. If you ask myself whether I see any, I would say, substantial differences between the 3, I don't know, because in terms of efficacy, I think overall response rate is rather comparable. Safety profile is also comparable in the 3, but I think that this is also good. You know, we have 3 options with a very high overall response rate, around 60 to 60-something%, a significant proportion of patients that would get very deep responses, complete response or better. And we know that the median progression-free survival is ranging between 11 to 17 for elranatamab, not yet reached for linvoseltamab, and patients that achieve these very deep responses really have very long duration of response, even beyond 2 years, which is very good and something exceptional, again, in the triple class exposed late line setting for multiple myeloma. Then we have talquetamab, which is targeting another antigen, which is also good because then we can sequence agents targeting different molecules in the surface of the myeloma cells. And I think that is very good news for patients in myeloma to have all these new options. If you ask whether I prefer CAR-T or bispecifics, maybe we can discuss this later.
Okay. Joe, do you have the same feeling?
I do. I mean, I think there's still so much to learn about all of these. Like even in the CAR-T discussion we've had, I bet you there'd be a difference opinion from the 5 of us as to whether or not when you bring CAR-T earlier, do people get more durable responses? Some people have said, oh, you're going to get, 2 years or so out of cilta-cel and a year or so out of ide-cel, whether you do it early or late. I actually think we're going to do better when we bring it forward. So I think we're still in that evolution phase. And I think your discussion about bispecifics is exactly the same. I agree with Paula very much. We have access to almost all of these bispecifics, whether in clinic or on clinical trial. I don't see a massive difference between each of them. However, they're all moving in a direction to make them, again, as I sort of said in that evolution, more effective and safer. And I think we still have a lot to learn in the pragmatic delivery of these drugs. I see a day where we will give them all outpatient, where we will have much less concern about cytokine release syndrome, where we will have less intense treatment with bispecifics to reduce the hypogammaglobulinemia and the infections that we're seeing now. Because, I mean, I don't know any center in the US that now continues, for example, to give teclistamab every week. We all de-escalate, and there was some nice data presented. Asad Usmani had a nice poster about de-escalation of teclistamab at EHA, and I think we're all, one of the themes we learned even at our IMWG summit was less is more, and I think we're learning that with bispecifics, whereas with CAR-T, it's one and done, which is great. Patients love that. And I think we always want to preserve that when we can. If I have a patient in front of me and we're talking about CAR-T versus bispecific, if they're eligible for CAR-T, I likely favor a CAR-T because of its slightly higher efficacy and that one and done. On the other hand, if the patient has very rapidly growing disease, we need to treat them right away. We can try and bridge them before a CAR-T, but sometimes we need to treat them right away. Or if we feel that they're not fit enough to go through the CAR-T process, although we can do it in most patients, then I may also favor the bispecific. But I do think the 202 versions, if you will, whether it's the same drug used differently or some of these newer agents, both for CAR T and bispecifics. And we saw a lot of new CAR Ts and some of the new bispecifics that you mentioned, including the ABBV drug for bispecifics, I think will move the field forward. Because here in the US, most myeloma patients are still treated in the community. And so the community physicians don't have the capacity as easily to do CAR T. They may be able to do bispecifics if we can find a way to do it fully outpatient. And my last comment, Mohamad, was that I was interested in some of the work that was presented mostly at ASCO, as some at EHA as well, around prophylactic tocilizumab for giving these bispecifics, right? I'm not sure it's the whole answer, but it's part of the strategy of reducing the fraction of patients that experience CRS, even if it's reducing the grade 1s, because those patients do need intervention as well, that we may be going in a direction to be a bit more aggressive with prophylaxis so that we have reduced cytokine release syndrome and hopefully less need to be in hospital and to have patients intervened on.
Thank you, Joe. And for the sake of completeness, I forgot to mention in the list cevostamab, which is directed against FcRH5.
Right.
Apologies. So Hermann, again, my question to you, would you put a bispecific as an immune therapy at the same level as CAR T cells? And what is your vision? And it's going to be the same question to Jesús about how to synergize between these two classes and maybe using bispecific as a bridge to CAR T cells, or the optimal sequence, how are we going to design it, especially that we're lucky your group has pioneered the first, I would say, widely used bispecific in hematology, namely blinatumomab in acute lymphoblastic leukemia. What are your thoughts?
No, first of all, I think we're going to see the same strategy as also in the CAR T cell field, that we are moving bispecifics antibodies to earlier line of therapy. The second one is, and that has nicely been addressed by Joe, is that we have to learn to better use bispecific antibodies. I think we overstimulate bispecific antibodies by giving them every week. And I think that's probably one of the things that we have learned in the last few months, and has nicely presented at COMy-EHA and EHA, that the strategy will be to extend the treatment-free interval to allow the T cells to recover and to be more effective. And I think with this, I would guess that we see even deeper responses and probably more prolonged duration of remission than we have seen up to now. But at the moment, if we compare CAR T cells and bispecifics, I think the overall response rate, the CR rate, and the progression-free survival is better for CAR T cells. On the other hand, as it has been pointed out, we need some time until the CAR T cells are ready. We have to bridge the patients. So patients with with a very aggressive myeloma are probably not ideal candidates for CAR T cell therapy. Then the question about the sequencing, there have been some reports, and we also had the chance to use this strategy to give a bispecific as a kind of bridging therapy. And that seems also to be a quite effective strategy, especially in late-line patients where we don't have any really good option to control the disease until the CAR T cells are ready. So I think bispecifics is clearly something that we can use probably more widely than CAR T cells. I don't think there's any age limit. We had treated patients up to age 90 with bispecific antibodies with really acceptable toxicity profile. You have to watch about infections, but I think that really can be done. And I think to have both CAR T cells and bispecifics is fantastic for our patients. But for both, we have to learn how to better use them, and probably we have to lose a lot about how to combine and to sequencing. And I think that will be the issue of a lot of trials that we're going to see in the next few months and years.
So Jesus, now you have the hardest question about the sequence, and I would make it even more difficult for you, because I'll throw in that we have also seen in the last few weeks the publication and the release of the first results of the DREAM7 and DREAM8 trials, bringing a new player there, an antibody drug conjugate, namely belantamab, directed against BCMA, with some very exciting results, I would guess. And maybe you're excited about these results. So it brings another player there.
Yeah, but before I go to this, if I am allowed, Mohamad, I will echo what has been said by Joe, that probably, and you mentioned, that we are not going to have CAR-Ts for every patient. The production will not allow it. And this, together with the community hospital or the small hospital in the different cities in Europe, I think the use of bispecific is going to be more popular in the worldwide. Second, I think bispecific can be optimized by being combined with either monoclonal antibodies or with immunomodulators. Therefore, I think there is clear room for having deeper responses and probably longer duration of the response by the combination. Third, and last but not least, regarding the sequence, I think the benefit of a prolonged treatment-free interval when you're using a second one of these drugs is very important. And it has been clearly shown that bispecifics work better after a long treatment-free interval of CAR-T than the other way around. If you give a CAR-T immediately after bispecific, the results are significantly poorer. Second message, to switch off the target. Treatment-free interval is the first, and then to switch the target. And Hermann has alluded, and we have also experienced before a CAR-T using even as a debulking a GPRC5D. But the data that was presented at EHA by Sajid Kumar on cevostamab in patients that have previously received a CAR-T were outstanding with 70% response rate. Therefore, I think this is very relevant to switch the class of target that we are using, making decisions. Then I will move into your question. The data on belantamab. If you would ask me 8 months ago, what do you think about belantamab? I would say, okay, unfortunately, this drug is not working. It has been demonstrated in the randomized study against Pondex, and unfortunately, it's not working, and the toxicity is an issue. Then, when we saw the results of the DREAM7 and 8, I said to some people, it's hard to believe. Look, it's 36 months PFS. It's the same of the best CAR-T. Okay, is a different patient population. This is clear. But we know that also the CAR-Ts in the early lines will be in this range. Then this is really remarkable. And also the frequency that you need to give this drug. You can stay for 2 or 3 months without giving the drug, and the response is maintained, and the toxicity is significantly reduced. Then I was really surprised.
Can I add to that, Mohamad, only because I completely agree with Jesus, of course, because I think we were all a little bit shocked at the depth of response, the duration of that response. But, you know, I have so many patients in my practice where, I mean, I've joked with one of them that they literally just have to smell the bottle of belantamab every 2 or 3 months. You know, there are some people that have that exquisite response. And we really do have a lot more to learn about going from class to class and from target to target. You know, some of the work we're doing in our lab in TGen is evaluating how people relapse when they relapse on each of these bispecific antibodies, and even the ones of the same target. So if I look at a patient that's relapsing on teclistamab versus elranatamab versus linvoseltamab, we actually see different genetic changes. So there may be an opportunity even within the same class. But I agree, this emerging real world data, the Mayo Group and others showing that ideally it's probably better to go from CAR T to bispecific with that treatment interval open, lengthy interval. But I love the fact that it's becoming complicated. I love the fact that we will hopefully have belantamab back, because every patient is different, and some patient may really benefit from just my treatment interval with belantamab now is literally every 8 to 12 weeks after the first 2 doses. So for many patients, especially those who live far away or may not be able to access the clinic that frequently, this could be a really great option for them. And I think Dream 7 and 8 also show to us that this drug is combinable. So we can combine it likely with multiple other agents with time, which of course is always an important strategy. So I love the complexity of not knowing the best sequence, of not knowing which is best, because then now I have this big menu of choices to bring to any individual patient, and we can weigh the pros and cons together and decide what's best.
Thank you.
Mohamad, you has bring the combination, and I think now we are really stick to single drug, single agents that produce 60-70% response rate. But there are some other agents that produce just 30% responses, and we consider that they have no value because 30% is not comparable. But don't forget daratumumab. Daratumumab single agent, the response rate was in that range. And now nobody discuss that this is part of the armamentarium of myeloma patients, upfront, relapse, etc. Therefore, I think we should also keep an eye in other drugs that have activity, but not so a strong activity. And probably in combination, they will reach a similar response rate to the bispecific or the CAR-Ts.
No, I think we are all in agreement that until we have cured all myeloma patients, we will need all drugs. And I think having the positive result of Dream 7 and Dream 8 was definitely a great news for the field. And I'm sure the drug will find its way and will provide benefit to many patients, especially, as you mentioned, given now the clinical judgment, I would say, they use based on clinical judgment and having these long intervals. But I will turn again to Hermann, because he has been always advocate of immune therapy, manipulating, harnessing the immune system. Antibody drug conjugates, I would personally consider them as a form of modern, fancy, great cytotoxic agent, I would say. Not exactly the type of agent modulating the immune system. So, Hermann, do you share the same excitement, or you still prefer to stick to the immune system first, because the immune system is fitter in the beginning, and then maybe later, or maybe situations where a cytotoxic activity may be more useful, I don't know, in high-risk disease and extramedullary disease, whatever. I don't know. What are your thoughts?
Oh, I completely agree with you. I think this is the main difference between an immunoconjugate, a bispecific, and a CAR T cell, that the immunoconjugate does not depend on T cell function and T cell fitness. And therefore, I think for me personally, I would rather position an immunoconjugate after a bispecific and a CAR T cell, when obviously the T cells are already kind of exhausted. There might be a difference in if we further define patients that are less likely to respond to a T cell based therapy. And I think there are some indications from lymphoma, but also myeloma, that there are very high risk patients that probably also the T cell function is not sufficient to kill the modified tumor cell. And in this situation, it might be an advantage to use the immunoconjugate earlier. I think the other advantage clearly is the combination, that you can actually, with the immune conjugation, you can use a lot of different drugs in addition, which probably will not be the case in CAR T cells, especially, and probably also less in with bispecific antibodies.
And also, I guess the beauty of CAR T cells is being a single agent, single shot treatment, and then wait and watch.
One and done. Yeah.
Absolutely. So, Paula, you've heard the opinion of Joe, Jesús, Hermann. There is some excitement. Hermann tried to modulate the opinion by maybe thinking about the right sequence. What would you envision as a positioning for antibody drug conjugates with CAR T cells and with bispecific?
Yeah, so I agree with all that has been said. So I think that the data is very good, both for the DREAMM-7 and the DREAMM-8, with a safety profile that is rather predictable, and that now we know how to handle and how to manage. So at the beginning, there was the concern of the ocular side effects of belantamab, but now I think that the majority of hematologists are aware, they know how to handle, they know that this is reversible, that by changing the schedule, it will go away. And I think that all of us may think that there are patients that are suited for belantamab, and then there are patients that are suited for T-cell redirecting therapy. So at least I have like these two different. So definitely, if you think that the patient is eligible for CAR T or eligible for bispecifics, you don't want to use another BCMA-targeted therapy with the possibility of that then hampering the effect of bispecifics or CAR Ts later because of down modulation of BCMA expression, in mutations in the target or whatever. So I think that belantamab combinations will be for those patients that are either not willing to go for CAR Ts or bispecifics for whatever reason, or that you do not feel they are good candidates or well-suited patients for those therapies. So I see, for example, belantamab BD or belantamab PD very well in a patient progressing after daratumumab lendex, older patient that eventually, you don't feel is a good candidate for bispecifics or CAR T. Although, and Hermann also alluded to that, we know that bispecifics can be delivered safely and with good efficacy in patients over the age of 75, even frail patients, and there are sub-analyses showing this. And we also know that we can do CAR T in patients over the age of 65 or 70 as well. But probably there are patients that you do not see eligible for those therapies, in which belantamab combinations will be ideal.
Okay, thank you, Paula. Let me push this discussion a little bit further, because while talking about bispecific CAR T cells and now antibody drug conjugates, actually the most widely used ones have the same target, BCMA. So that brings me whether we can rely on the same target, same tumor antigen in a given patient at all disease steps. And this is about the mechanism of resistance. I know BCMA is a great target. It's always, in general, highly expressed, although there may be some subtle differences between high expression and downregulation of its expression, even loss in some cases. So how do you view this issue of resistance to the BCMA pathway, and whether it is more relevant to the immune therapies versus the immune conjugates? Jesús.
Okay, I think it's clearly more relevant to the immune therapies, to the immune conjugates. Hermann has pointed out, in the immune conjugated, if you have the target, you can deliver, but the drug, this is the case. But you need to have the target.
Exactly.
And the targets should be, sometimes you don't need to be functional, but you need to have the antigen to be put the drug inside. The point now is that in the past, we didn't look, when we give a drug, to such a target. We just give chemotherapy, and that was done. And even for the CD38 antibodies, we didn't screen again for the expression of the target. And we know that with very little molecules, you can be effective. And this is the reason why I think that in that way, in that sense, as you have mentioned, probably will be easier if you have a problem with the target to deliver a conjugated.
Joe, do you have the same opinion?
Yeah, no, I mean, I think it's been outlined. I think the challenge, honestly, is we don't have an easy clinically available measure of BCMA resistance yet. Obviously, we're working on it, but to me, when I express it simply to community oncologists and others, BCMA is clearly different than CD38. If I treat a patient with a CD38 antibody and they're progressing on it, I'm not likely going to salvage them with another CD38. Whereas with BCMA, the true BCMA loss, as we know, only happens maybe in about 5% of patients. And not all BCMA is the same, is perhaps one way to look at it. I do believe that there are unifying features of it. As I mentioned, the work that we're trying to do in our lab is make that distinction. And so I wouldn't want someone to think, oh, because they've had a BCMA therapy, we just need to abandon it. Yes, I do think it's nice to have a time interval between things where there may be an opportunity to regenerate more of it, but I think we're still a lot to learn, and I know this will probably be a lead into your next section, but we also still have a lot to learn about T-cell health and how much that plays into the use of the BCMA target, right? If I could create a magic tool tomorrow, it would be the perfect T-cell index, that I could measure someone's T-cell health, right? It was at COMy that I was sitting there quietly right in front of you in my seat, and Sagar Lonio looked at me and he saw me sipping my cappuccino, and he claimed that mezigdomide was a cappuccino to T-cells, and he said, just like this cappuccino is reviving Joe, I can revive T-cells with this drug, right? So that is a whole other area of discussion. It's one thing we've learned with CAR T now, and even bispecifics. Don't give your patient a T-cell toxic drug immediately before, right? We try to avoid alkylators, in particular things like melphalan or bendamustine, immediately before collection of T-cells or bispecifics. That we want to use drugs that are at least neutral, if not pro T-cell. Like we use a lot of selinexor here in the US in the line prior to T-cell therapies. But could we actually use drugs that better your T-cells is still to be discussed, right? Whether selinexor can do that, whether cell mods can do that. But I do think that is going to be a big part of our future. And I'm always with ears wide open to listen to Hermann when he discusses this topic, because I think he's one of the world experts in the area of understanding T-cell health, that I think that will influence in the future give us more clarity as to not only sequencing, but what is the ideal therapy for patients, because some patients sadly have very strong T-cell health, but others do not have significant T-cell health.
So before moving to the small molecules, as you mentioned, Joe, Hermann, what can you tell us about the mechanism of resistance to the T-cell redirecting agents like CAR T-cells, but also bispecific, not only the BCMA as a target, but also GPRC5D or FCRH5? What is the current knowledge?
And I think what we unfortunately had to learn is that also there are resistance mechanisms to immunotherapy. And I think Joe has nicely pointed out the issue of T-cell exhaustion, T-cell fitness, and I think we have to learn a lot more about this. But I guess in a patient who has an exhausted T-cell system, even CAR T-cells and bispecifics will not work. On the other hand, we also learned that the tumor cell is kind of adapting to this immunotherapy. And I think if you expose a highly genetically unstable tumor cell to a T cell that is only addressing one surface antigen on the tumor cell, it's very likely that there will be some target antigen loss, and that has been described by several groups for CAR T cells and even more for bispecific antibodies, where there have been a complete biallelic loss of the genes that are encoding for the target antigens, or mutations that reduce the efficacy of CAR T cells and bispecific. And that has not only been shown for BCMA, but also for GPRC5D. And I guess we are also going to learn this about FCRH5.
Yeah. Definitely.
Okay, thank you very much. So that brings me to the last part of this discussion, and this is about the novel so-called the small molecules. And I think we all know that, for instance, historically, IMiDs, whether thalidomide, lenalidomide, or pomalidomide, they have been really the pillars of myeloma therapy. Easy to use, oral drugs, excellent safety profile, and they have been transformative in multiple myeloma therapy, not only in the relapse setting as they were initially developed and approved, but also now in the frontline setting. And we have now some good news about novel, I would say, next generation IMiDs, if you allow me to call them like this. For instance, iberdomide and mezigdomide. Mezigdomide is a novel cereblon E3 ubiquitin ligase modulator. It has a potent antiproliferative and anti-tumor activity in different preclinical myeloma models, including those resistant to lenalidomide and pomalidomide. And we had, in September 2023, a beautiful New England Journal of Medicine paper by Paul Richardson and colleagues. They published a phase 1/2 trial using mezigdomide and dexamethasone in really advanced, heavily pretreated refractory patient. If I remember well, I think they have received a median of 7 or 8 prior lines of therapies. And despite this, actually, just by using mezigdomide and dexamethasone, there was a very interesting response rate of 41%. And the median duration of response was 7.5 months, 8 months maybe, which is quite amazing. And so here I would like to get your thoughts, guys, on where to position these new cell modes. Joe, you already alluded to the fact, and I'm glad you enjoyed the cappuccino at COMy, that they are like a sort of an enhancer, or they can synergize with our current popular immune therapies, whether CAR T cells or maybe bispecific. Paula, any comments? What do you think about the cell modes? Because I like these oral, easy-to-use drugs, and they have, of course, some hematologic toxicity, but we are hematologists, so our job is to manage hematologic toxicity in general.
Yeah, definitely. So, you know, if there is any negative point of having all this innovation in the field of myeloma CAR Ts bispecifics, is that the bar now is very high for new agents to come. You know, so so before, you know, pomalidomide, daratumumab, we were discussing before, no, they were all approved with 30% overall response rate in settings of unmet medical need. Now we have in that setting, so triple class exposed, we know that with conventional therapy, overall response is only 30%, PFS is shorter than 5 months. CAR Ts and bispecific did increase this significantly, and now we have overall response rate between 60 to 90 something percent with CAR Ts and bispecifics in that triple class exposed setting. So unfortunately, when you see the data in that triple class exposed setting with iberdomide or mezigdomide, overall response rate is 30%. So then there is this difficulty in pushing these drugs for this approval in this setting with that efficacy data. However, as you mentioned, these are oral drugs, very convenient, with very low safety issues, so no major safety toxicity issues. They are even improving on the safety profile of IMiDs, so POM and LEN, and they are likely to be used in earlier settings when we have the data from the phase 3 randomized studies that are ongoing now, and iberdomide, we have some data already in maintenance setting showing an increase in the depth of response in patients after autologous stem cell transplant. So I do believe these drugs will be used in the future, but we will need to wait a little longer to get the phase 3 data release to be able to use these drugs. But definitely, and also Jesús alluded before, that they can be also a good partner for bispecific antibodies, both mezigdomide or iberdomide. That could be also good partners for CAR-Ts, for maintenance after CAR-Ts eventually. So definitely, I think that these drugs will be used in the future in myeloma.
Excellent. That seems to be very exciting. Joe?
Yeah, it's hard to add to that because she summarized it so well. But I mean, we need more agents that are easily delivered, that can be combined with almost any other drug. I mean, if you want a successful drug in myeloma, you show you have single agent activity, show that your toxicities are predictable and manageable, and show that you can be promiscuous, right? You can partner with just about everybody else. And I think that's what these drugs are showing. I do think there is a difference between iberdomide and mezigdomide. We're seeing this in the clinic and the profile and so on. They are obviously very different drugs. They're not just a different variation on the theme. I think mezigdomide has more immunosuppression, more neutropenia in particular that we have to be careful with. And again, like with every drug, as we've said, there is an evolution. We learn to manage them a little bit better, but I am very excited about the use of them. And I'm particularly interested in some of the studies where we've been seeing them used after CAR-T or after bispecific antibodies. As Hermann mentioned, there's good biological rationale for a drug conjugate at that point. But there may be rationale also for giving drugs like this, just pragmatically, because they're so easily delivered, and because obviously CAR-T bispecifics are fantastic, but our patients still relapse. It's not a cure. So I really do think that they will play a role. And then lastly, I would say we still do have some, very frail older patients where it is just very challenging to consistently give them infusional, even if it's subcutaneous drugs like bispecifics. So there will be a niche for this in patients who really just want a simple oral agent delivered in the way that we can give cell mods.
Thank you, Joe. Hermann, how do you view these new cell modes? And again, I personally believe that they can be great enhancers to the immune system. Actually, it's not about cell modes against this or this agent, but rather how we can put all this together to optimize the treatment, and maybe the issue of whatever T-cell exhaustion can be reversed by these cell modes.
No, I like Joe's comment about the cappuccino and the T cells. I think that's very nice. I will never forget that one. That's good. And on the other hand, I think iberdomide, and I think we have seen quite a lot of trials now. It's a very interesting agent as a kind of maintenance. It's more effective than the IMiDs. It's less hematotoxic. So I think this is really something which we can look forward to use in the future in a certain treatment phase.
So Jesús, while we're talking about immune therapies and cell modes and modulating the immune system, but maybe there is room to combine these cell modes with simply the classical agents we're using, like carfilzomib, for instance. Proteasome inhibitors, have been really another pillar of advance in multiple myeloma. What do you think?
No, I think, first of all, we need to recognize what is the in vitro efficacy of iberdomide and mezigdomide as compared to lenalidomide and pomalidomide. In vitro, the EC50 for binding of cereblon and the subsequent degradation of Aiolos and Icaros is significantly more potent than iberdomide than the two other drugs that we have already available, lenalidomide and pomalidomide. Regarding mezigdomide, is even more potent. In fact, I used to say that mezigdomide, the name is, if you don't want to forget about something good, is Messi, the football player. Then, for me, this is the in vitro data is very convincing. Now we need to demonstrate that this translates into such a significant difference also in the clinical setting. But I'm not looking iberdomide and even mezigdomide as a single agent at all. I'm thinking that we are going to replace the VRD probably by the
VID or VMD,
iberdomide and dexamethasone, or the DARA or the EHA. I think this is one of the places that these drugs should be positioned, and the other is in the maintenance. Don't forget that lenalidomide gives you more than 2 years benefit over no maintenance, lenalidomide. And this need to be surpassed by other drugs. Before we said that, okay, lenalidomide is not enough. Okay, this means that lenalidomide is very potent, but has side effects. Iberdomide, I hope, is going to be more potent for maintenance. And with reduced toxicity, as Hermann has mentioned. Therefore, these drugs, both of them, one I think is going to replace lenalidomide. I see the other replacing pomalidomide. Mezigdomide will have more the drug to rescue patients that are resistant to iberdomide, but both of them we will have pretty sure in the treatment armamentarium.
Fantastic. So we have reached the last couple of minutes of this superb discussion. So I have one question, one concluding remark from each of you. What are your hopes for the near future in the field? Paula.
Yeah, this is always a very difficult question. So I hope that with all the armamentarium that we have now, we will be able to cure a significant proportion of patients and to use the drugs in the better way, because I think that we have discussed a lot, how we can improve the way we use the drugs, the way we deliver the drugs, the schedules, fixed duration, all this toxicity. So to make also life for the patient much more easy. So this is my dream, I would say.
Joe?
Oh, my dream is very similar to Paula's. I think there's so much more to learn with what we have, but maybe I'll also put a shout out to, can I call it CAR-T and bispecifics 202? We did see a lot of new data from new CAR-Ts, from other emerging bispecifics, even allo CAR-T. Can I use that phrase now? I know we're not quite there yet, but the idea of not having to collect T cells from a patient, I know we still have more to do in that realm, but I'm excited about the next wave as well that will, I think, take us even further, both in quantity and quality of life of our patients, because as Paula nicely pointed out, we don't treat myeloma, we treat people.
Thank you. Hermann?
I think it's a great time to work in the field of multiple myeloma. 50 new drugs in the last 10 years, so many new options. And I think it's also great for our patients. I've seen several patients today that are now on treatment or off treatment since 15, 20 years. So we are really curing patients. And I think that's something, when I was starting treating patients with multiple myeloma, that was seen as completely impossible. So great times for patients and for myeloma experts.
Jesus, you have the last word.
Okay. I think for young people like Paula, who would be in the future, should need to look for another disease.
It's okay. I am not that young, to be honest.
No, but at the same time, I would like to remember how difficult it is to cure myeloma, because the immune system in myeloma play a very important role to promote drug resistance, to promote cell resistance. And I think we need to continue to explore ways to try to overcome the interaction between the tumor cell and the microenvironment, because for me, this is one of the more challenging situations that we're facing for curing myeloma.
Well, thank you all for these words of wisdom. It has been a true delight to moderate this discussion with top faculty, but also friends. I fully agree that it is quite an exciting era, and we have good news every day when it comes to multiple myeloma, but we are all committed to bring the best for patient. And obviously, we've never been so close to cure. Of course, we can debate the meaning and definition of cure, but at the end of the day, I think we are seeing more and more patients living long and well. And at the end of the day, that is the important goal.
Mohamad, may I ask you a question? Do you consider that CML is a curable disease?
Well, I didn't comment on this. I could say, well, today, CML, which is a very unique disease, it depends what is cure. If cure is getting rid of the leukemic stem cells, I would say no. But if cure is about living long, similar to everybody and well.
Just taking a pill.
Taking a pill.
So, for me, this is cure.
We're not yet there in myeloma. So
no. But what I was trying to point it out, that we may be in a situation in myeloma that patients may need a sort of maintenance due to the immune system. But for me, this would not be against of the idea of we are curing patients. For me, curing is to have the opportunity to live the same life as the other people. Good quality of life and long life.
So definitely we'll need to have many discussions, because there are still a lot of issues to debate. But again, thank you all for sharing your knowledge, your wisdom. Thank you for your time. Thanks to our audience. And I hope you have enjoyed it. I personally learned a lot from this distinguished faculty. And I hope you will have wherever you are, a good day. And we'll see you very soon in another ICH activity. For the time being, please stay safe and keep well. See you soon.
Thank you.
Thank you.
Thank you.
Pleasure.